One of the most intriguing and confusing clinical conditions seen commonly in a breast clinic nowadays is chronic granulomatous mastitis. It is intriguing because of the diagnostic dilemmas involved as well as multiple treatment options without any clearly laid out guidelines as yet. Once thought to be rare, it has become a relatively common condition, accounts for about 10% of the benign breast conditions that I see in my OPD. Patients usually come after undergoing multiple consultations, multiple treatment and multiple surgical excisions. They are most commonly in the age group of 28 to 35 years with young children, usually having stopped lactation about 1 to 3 years prior to symptoms. The clinical presentation is very varied. Patients may present with diffuse lumps, a few lumpy lesions restricted to a particular quadrant of the breast. They may also present with recurrent discharging sinuses or recurrent abscesses with severe pain and tenderness. There could be stigmata from previous discharging sinuses in the form of dried sinus openings. So, how do we come to a conclusion regarding the diagnosis? Mammography may reveal ill-defined nodular densities or focal asymmetric densities or diffuse increased density. Sonomammography may reveal ill-defined lesions with tubular extensions or mass lesions with irregular borders. There may be small abscesses with tracts draining to the surface in acute conditions. MRI is mainly used to distinguish from malignant lesions. MRI may show separate or confluent abscesses or mass-like segmental contrast enhancement or non-mass-like contrast enhanced areas. Usually a core biopsy or a discharge from the sinus opening may be sent for cytology or culture or AFB. Granulomas may be seen on biopsy. Culture is usually inconclusive. A tubercular profile may be sent, but in spite of all these investigations, most patients remain in the idiopathic category. Treatment of chronic granulomatous mastitis is a highly debatable topic. Some people believe in surgical excision, but in my opinion, it works only with a very localized disease restricted to a particular quadrant, maybe. Mostly the disease is progressive. It is not amenable to cure by surgical means because repeated debridements cannot be performed, which results in mutilation of the breast. So, presently, medical management is the cornerstone of treatment. Corticosteroids, mainly oral prednisolone, starting with 20 milligrams daily and continued for 2 to 3 weeks up to 6 weeks and tapered gradually, does help to bring the disease under control. Moxifloxacin, cloxacillin, clindamycin, linezolid are the antibiotics which are usually effective in case of superadded infection. Empiric antitubercular treatment may be advised in certain cases where the disease is resistant to treatment by any other means. Local wound care in the form of sterile dressings, aspiration of infected fluid, and prevention of secondary infections with adequate wound care usually help in the management of chronic granulomatous mastitis. So, to conclude, chronic granulomatous mastitis is most commonly idiopathic with no definitive pathological findings. Thought to be an autoimmune condition, corticosteroids remain the mainstay of treatment. Antibiotics are commonly used for superadded infections and are mostly required continuously for 6 to 8 weeks to prevent repeated painful exacerbations. Antitubercular 4-drug regimen has been found to be beneficial in cases refractory to standard treatment. Surgical excision, debridement are not curative, as extensions of the condition and recurrences are very common, leading to very poor cosmesis. Reassurance is essential, as the treatment regimen is long and protracted, and patients have to maintain their patience. Thank you for watching this presentation. It has been made to increase awareness about chronic breast conditions, mainly infective and inflammatory conditions, which pose a common and intriguing health hazard in today's scenario, mainly in young women in the post-lactational phase. Various treatments which have been described or tried by different clinicians usually yield no results. Whatever I have put forward is my own experience in this area. Thank you again.